sorry for that. So now let me start again. Well, so these are tissue layers that surround the fetus that separate it from the lining of the uterus. Okay, so they basically separate it from the mother, and they are zygotic in origin, hence they are products of conception. So this is a very important point because since they are zygotic, it means they can be used in, for example, in paternal studies, because to know like who is the father of the child or such things. We will discuss about that in the next few slides. So we have four components: the amniotic membrane, the yolk sac, the allantois. Okay, some people call it allantua, but just stick to allantois, and the chorionic plate. So this is the amniotic fluid here. Then you have the amnion. So the objectives will be to state the formation and the timing of each membrane, to state the function of each membrane, to state the fate of each membrane, and any related clinical aspects. So we'll start with the first fetal membrane. So it's a membrane, it's the amniotic membrane. So if you remember your week 2, usually have the bilaminar disc. So we have this the epiblast and the hypoblast. So this is the amniotic sac above and the yolk sac below. Okay. So this amniotic membrane is formed by the migration of the amnioblast cells from the epiblast. You see, this is the epiblast. So there's like a migration of the amnioblast cells. Though they migrate like in this fashion. Then now they go as squamous cells, but they retain their connections. So you've done the epithelium, so you know like what I mean by squamous. So they migrate as squamous cells. So this is the amniotic membrane, and then they secrete amniotic fluid to the amniotic cavity. So they secrete amniotic fluid to this amniotic cavity. So the size of the amniotic fluid, the size of the amniotic sac usually increases as the pregnancy advances. So I'm not sure if you've done embryonic folding, but there's usually transverse folding and craniocaudal folding. So this is transverse folding that has been shown here. So as the pregnancy advances, the amniotic sac, the size usually increases. This will be relevant when we are discussing things like oligohydramnios, which results in less amniotic fluid. So the amniotic fluid. So I'm going to discuss the sources of the amniotic fluid. So I will divide this into three periods. So we have the embryonic period before 8 weeks, the early fetal period, and the late fetal period. So in the early fetal period, that is before 8 weeks, it's the amnioblasts. See, I'd say it here. The amnioblasts, these ones now are the ones that are secreting the what do we call it, amniotic fluid. So the amnioblast cells and the embryonic surfaces. So before 8 weeks is this only, these two things are the ones that are secreting the amniotic fluid. The next thing, in early fetal period, we have category 1, and then you have fetal urine and fetal lung secretions. So this category 1, it's not a conventional term, like, there's something known as category 1. I've just used it in this presentation to mean amnioblast cells and embryonic surfaces like epiblast. So during the early fetal period, there will be fetal lung secretions and be fetal urine. These are the main ones, but also these other ones will take part in as a source of the amniotic fluid. So when you'll be developing the urinary system, you'll get to know the different set of kidneys that will be forming. And yeah, so during this time, it's only the fetal urine, fetal lung secretions, and these other two. Okay, category one is just to mean these other two. And then the late fetal period, this is in the late second and third semester, we have mainly category two. Okay, category two now, I mean fetal urine and fetal lung secretions, and then now fetal oral and fetal nasal secretions. But overall, the fetal urine and the fetal lung secretions are the main ones, because this time it's when the kidneys are forming. So that's the sources of amniotic fluid. So we have the sources, now we have the clearance of the amniotic fluid. So uh, how do we clear amniotic fluid? It's by fetal swallowing. The fetus swallows the amniotic fluid. That's why I started by asking if you've ever drank your urine. So it's not like correct, but yeah, you've ever drank your urine, because one of the methods of clearance of the amniotic fluid is fetal swallowing. So fetal swallowing, and then it goes to the fetal JT after you've swallowed, and then it's fetal absorption, and then fetal circulation. So this is the main method. So when you asked in an MCQ, what's the main method of Okay, so I see Najib has asked me to repeat what category one and what category two is. So okay, let me just start the amniotic fluid thing all again. So the sources of the amniotic fluid, we have, and in the embryonic period, before 8 weeks, we have the amnioblast cells and the embryonic surfaces, like the epiblast cells. So these are the ones that are secreting the amniotic fluid. The fetal urine and the fetal lung secretions are the ones now secreting the amniotic fluid. But we also have these other two, okay? So I've just put them as category one, just to mean, although we have fetal urine and fetal lung secretions, also these first ones play a role. And then now in the late fetal period, we have mainly category two, meaning fetal urine and fetal lung secretions. So these ones are the main sources of amniotic fluid. So if just someone just asks you randomly, what is the main source of amniotic fluid? It's the fetal urine. But just see, that's why I've said mainly category two to mean these two here. But we also have fetal oral and fetal nasal secretions. Okay, so those are the sources of amniotic fluid. And then now we have clearance is fetal swallowing. Okay, Najib, I believe I've answered your question. So, okay, any question by there before I continue? Yeah, she said yes, so it's fine. So, functions of the amniotic
Okay.
sac. So, we have these ones you knew from primary and high school. It protects the fetus from trauma to maternal abdomen. It also cushions the umbilical cord from. So I'm seeing this category one thing and category two thing is bringing problems. So let me just say in embryonic period, we have the amnioblast cells and the embryonic surfaces. And then in the early fetal period, we have the fetal urine, fetal lung secretions, amnioblast cells, and the embryonic surfaces. And then in the last one, we have fetal urine, fetal lung secretions, uh, yeah, and the fetal oral and fetal nasal secretions. So back to the functions of the amniotic sac. So this fluid, the amniotic fluid usually provides necessary environment for the normal development of the fetal lungs, the musculoskeletal system, and the GIT. Okay, so the kicking of the baby, so that really helps. So it has also a role in thermoregulation and also lubrication. Sorry. when when giving birth. Okay, that breaking of the water. So the fate, so the amniotic membrane usually tears around the time of delivery. So the membrane is expelled as after birth together with the placenta. So the clinical aspects, we have the amniocentesis, the oligohydramnios, the polyhydramnios, and the amniotic band disruption syndrome. So let me now go to amniocentesis. So yeah, this is the amniocentesis. So we go now to the story and then I go back to the picture. So it's an ultrasound guided procedure of obtaining amniotic fluid. So it's basically for obtaining amniotic fluid. So they fetal membranes are zygotic in origin, hence they are products of conception, as I had alluded earlier. So the tissues have the same genetic makeup as the fetus. So they can be used in genetic studies, like for the paternity to know who is the father of the kid or not. So yeah, but yeah, that's one of the use of this amniotic membrane. And then it's used for determining the genetic disorders like Edward, Patau, Down syndrome, because there's zygotic in origin. So they are, it's like they're related to more the as in when you take an examination of the fetal membrane, it should be a representation of the child. Okay, so it also can be used to assess the level of alpha fetal proteins. So these alpha fetal proteins, they when we have GIT or neural tube defects, they usually there is an increased levels of alpha fetal protein. So whenever we see an increased level of alpha fetal proteins, we know they might be an neurotube defect, like the spina bifida, spina etc, the JT malformations. So the disadvantages the the amniocentesis, it's a source of infection. So, 1 minute. Yeah, so this is how you take the amniocentesis. So you have the skin, the fascia, and then the uterine wall. So it's basically this is a syringe that used to obtain the amniotic fluid. Okay. So during that, it can lead to it's a source of infection. Okay. So and then another disadvantage, you can only do it in safely in the second trimester, because as opposed to chorionic villus sampling. So chorionic villus sampling I'll discuss much later. So you can do it only in the second trimester, because this is when the kidneys have properly formed. So yeah, so that's another disadvantage. You can only do it late. So an advantage, it's relatively safer compared to chorionic villus sampling. You will you will you will I will discuss chorionic villus sampling later. So another clinical aspect is oligohydramnios. So oligohydramnios is when the amniotic fluid volume is less than the expected gestational age, right? So what are the mechanisms of oligohydramnios? We can have reduced production, meaning the sources of amniotic fluid are not producing enough amniotic fluid. So we have reduced production, and we can also have increased clearance when, say, I'd say the main method of here clearing of amniotic fluid is fetal swallowing. So when you have increased clearance, it can result in oligohydramnios, and when you have reduced production. So if these things produce less amniotic fluid, you can have oligohydramnios. So oligo is few, and then hydramnios is hydra is like water. Okay, so reduced production. So like you're supposed to reason what can result in reduced production of amniotic fluid. Okay, so first is the renal abnormalities like e.g. renal agenesis, no, kidney agenesis. As I had said earlier, fetal urine is the main source of amniotic fluid. So so if the kidney is not formed, so urine is not formed, so it means you'll not be forming a lot of amniotic fluid. That's why you'll have oligohydramnios. Then fetal demise. So this is no just common sense because when the fetus dies, there'll be less amniotic fluid. Then also we have intrauterine growth restrictions. This is where just the fetus is smaller for that gestational age. So when the fetus is smaller, definitely the amniotic fluid volume is will reduce. So this can be a marker of oligohydramnios. So so that's reduced production. Then we can have increased clearance. Increased clearance is when we have preterm rupture of membrane. So and the fetal membranes they rupture prematurely. So definitely the amniotic fluid volume will decrease. So I've put for you these two you go research how does aneuploidy cause increased clearance, hence oligohydramnios, and how does drugs, some of the drugs taken during, uh, so what are the drugs that can cause oligohydramnios? So go research on that. So we have the complications of oligohydramnios. So we have pulmonary hypoplasia, fetal limb anomalies, and fetal demise. Okay, let me go to a picture first. Yeah. So here, so like this fetal limb anomalies, how it comes about. See, I had said earlier uh, that the amniotic fluid helps in helps in the development of the musculoskeletal system. So it means if you have less fluid, you will have like limb deformities because maybe the baby is not kicking and all. So yeah, so we have limb deformities. You see, like in this kid, and then you can also have pulmonary hypoplasia. Pulmonary, pulmons are lungs. So and this can cause respiratory failure. So this is just a repeat of what I'd said. Bilateral renal agenesis. So here we have is usually like when you hear of acellular, it means it has not been formed, and then so we have renal agenesis and then reduced fetal urine excretions, and now which can result in oligohydramnios. So yeah, see pulmonary hyperplasia, fetal limb anomalies, and then when we have oligohydramnios, we fear for umbilical cord compression. And when the umbilical cord is compressed in any way, it can result in fetal death. So this is actually the most important, fetal demise as a result of umbilical cord compression. Yeah, so it's good to take note of these three. So now we come to polyhydramnios. Polyhydramnios is a lot of amniotic fluid. Poly just a lot, and then hydra still amniotic fluid. So you're supposed to reason what can cause polyhydramnios. Okay, so when you have reduced clearance, so it means less amniotic fluid is being cleared. So it means you'll have a lot of amniotic fluid. And then when you have increased production, like what is supposed to reason what can result in increased production of amniotic fluid. So let's start here with the reduced clearance. So this is reduced fetal swallowing. So constructive anomalies of the GIT. So when you have constructive anomalies of the GIT, it means like the process of swallowing it has been impeded. So it means you're not clearing enough amniotic fluid. So definitely there will be polyhydramnios. Another one is a defective swallowing reflex. So this can be brought by CNS anomalies. So you will come to learn the swallowing reflex later in the year. So when you have a CNS anomaly, because this swallowing reflex is mediated by the central nervous system, it means basically you're not swallowing properly. So you can just say that in a layman's term. You're not swallowing properly. So that's why it will lead to polyhydramnios because there will be reduced clearance of the amniotic fluid, and also craniofacial anomalies, e.g., cleft palate. You see, you have craniofacial, the craniofacial, I can call it apparatus, is used in swallowing because no, like the palate and all. So if you have any craniofacial anomaly, it means you will affect swallowing of the amniotic fluid. So it will result in polyhydramnia. So another mechanism is increased production. Okay, so increased production is, for example, you have multiple pregnancies, so you'll definitely have a lot of amniotic fluid. Okay, then now we have other things like maternal diabetes, fetal cardiac anomalies. This you go research on yourself. I've put for you there, you go research. But close to 50% are usually idiopathic. So there is no like a mechanism really known about it. But yeah, so at least know, like, just know that when you have polyhydramnios, you have reduced clearance. So then you think, what can cause the amniotic fluid to be cleared in a reduced manner? Yeah, then you see that will help you understand other than maybe cram or something. So we have the complications of the polyhydramnios. So when you have polyhydramnios, like, so you have a lot of amniotic fluid. So like it can, it's a lot. So it can result in an premature rupture of membranes. Cause so we can say polyhydramnios can lead to oligohydramnios because the amniotic fluid is a lot. So it it maybe the amniotic membrane ruptures earlier. So yeah, so we have here preterm rupture of membranes as a result of polyhydramnios. Then you have the umbilical cord can tie around the neck. Then now we have the it's called this is called a true knot. So you can be brought in a sport exam. So this is a true knot. The umbilical cord like can form a knot here. Then it can also lead into a breech birth where, as you expect, the head to come out fast, but it's the opposite. So we also have amniotic band disruption syndromes where these are usually called constriction rings. See here, there's a constriction ring around the abdomen, around this region. Then you have a constriction ring. Also, this constriction ring, see, it can even lead to an amputation of the limb. You see, this is also a constriction ring. It usually mostly affects the limbs, but it can also affect other parts. So this is also a constriction ring. Yeah. So I'm done with the amniotic membrane. So any question, you can maybe unmute and ask a question before I continue. Okay, so there's no question. So I just continue. So the yolk sac is formed in the second week of development by the migrating cells of the hypoblast. So we'll still go back to this thing where we had the epiblast and the hypoblast. Okay, so now this is the hypoblast. So it secretes. It's like the cells migrate this way. See, they migrate this way. So yeah, that's basically the formation of the yolk sac. So it's migrating cells of the hypoblast. Uh, yes. So a functions of the yolk sac, it's used in early hematopoiesis. Hematopoiesis is basically blood formation. It's also a site of early nutrient supply. It also it gives rise to the primordial germ cell. So you had discussed, I believe we've discussed about primordial germ cells somewhere. So the fate of the yolk sac. The dorsal part of the yolk sac is incorporated into the embryo during the embryonic folding. So, like you have this part is usually incorporated this way. Actually, the dorsal part central. So this dorsal part is usually incorporated into the embryo during embryonic folding, and then the ventral part. First of all, It should degenerate initially as the vitelline duct. So the ventral part of the yolk sac it should degenerate as the vitelline duct, initially as the vitelline duct, and then the vitelline duct should disappear. Okay, yeah. So let me go to a picture. Okay, let me start with the sorry. Let me start with these pictures before now reading for you this story. So here we have the abdominal wall, and then we have the vitelline duct. As I had said, the vitelline duct is supposed to degenerate, but what if it does not degenerate? Will form a fistula. A fistula is an abnormal connection, like any abnormal connection. You can call it a fistula, right? So you have the abdominal wall, and then the vitelline duct does not degenerate. So like you form this fistula. So the connection between the yolk sac outside and the primordial gut. So yeah, that this one. So point number one, two, three, four. Point number four: persistence of a vitelline duct with a patent luminal connection to the anterior abdominal wall results in a vitelline duct fistula. So this also is like a fistula, but now we have a cyst at the center. So this one we call it a vitelline duct cyst, and then this one we call it a vitelline duct fistula. Then this we just have it's like a sinus, so we call it a vitelline duct sinus. So a sinus is it's basically it's like a tract with a blind end. So yeah, so this is the vitelline duct sinus, this is the vitelline duct cyst, then this is the vitelline duct fistula. So we have something known as the Merkel's diverticulum. This one here, this is the Merkel's diverticulum. So it's on the left, it's persistence of the vitelline duct and it's still attached to the intestines. Okay, so the type of cells in the Merkel's diverticulum are similar to the type of cells found in the stomach. So they usually are acidic. So you can imagine what can happen. So here we have the persistence of this vitelline duct, but with a connection to the intestine. Okay. So someone is asking the difference between the fistula and the cyst. This is the only difference. This cyst here, like one forms a cyst and one does not form a cyst. This round thing, one has this thing and the one does not have. So yeah, so that's basically all I have for the yolk sac. So now let's go to the allantois. So allantois is the extension of the yolk sac into the connecting stalk. So the allantois, so this is the allantois. It's just a connection of the yolk sac into the connecting stalk. So it has similar functions of the yolk sac. Because I've put a star, but it's an extension. So basically, it almost has similar functions, and it also contributes to formation of the umbilical vessels. So this is the allantois. So let me start with the picture and then I'll go read these notes for you. So like if you follow this picture clearly, we have like you see it that it has been written the hindgut. So this is the primordial GIT, all this one. And then now we have the urogenital system here. So here, this is the primordium of the urogenital system. So we have something known as a cloaca. The cloaca is just it's a point where there is a connection between the hindgut, like the primitive gut, and the like the primitive urogenital system. So the cloaca, it's a region where the allantois, cloaca, the region where the allantois and the, not put it correctly, cloaca represents the primitive connection, yeah, between the urogenital tract and the GIT. Okay, so here you have the urogenital, like this is to represent the GIT, and this is to represent the like the primitive urogenital system. So when we discuss later in the year the development of these two systems, we'll come to know that there is a separation. So the hindgut is separate, and the primitive urogenital system is separate. So the anterior part of the cloaca is continuous with the allantois. You see this one here. The anterior part is in connection with the allantois. So, sorry. Uh, the anterior part of the cloaca is continuous with the allantois, and then the lower end is incorporated to form the urinary bladder. So the upper part of the allantois should degenerate as something known as urachus. So the urachus later becomes the median umbilical ligament. So
No, I can.
so
You are scary. You look like a witch.
So here we have the plot. Please mute whoever. Samuel, please mute. Okay, so let me continue. Okay, so uh, the anterior part of the cloaca is continuous with the allantois, and the lower end is usually incorporated to form the urinary bladder. So the upper part of the allantois degenerates as the urachus, and the urachus later becomes the median umbilical ligament. So yeah, basically this is the median umbilical ligament. When you will be dissecting the abdominal wall, you'll come to see it, the median umbilical ligament. Okay, so it should degenerate as the median umbilical ligament. So let's say, for example, it does not degenerate. So see here we have the bladder, because we see the bladder basically comes from the cloaca. So this is the bladder. So we're supposed to reason what can happen if there's a abnormal connection between the bladder, and then like, this is just in the abdominal wall around here. So they can be leaking of urine through the abdominal wall in case this does not degenerate as the umbilical, like the median umbilical ligament. Yeah. So the lower part of the allantois forms the bladder, the upper part should degenerate. Okay. So now let me go to the clinical correlates. Again, I'll start with the picture, and then I'll go to the notes. So it's basically the same concept. You have a fistula here, a sinus, a cyst, and a bladder diverticulum. As I had said, a fistula is abdominal, what do we call it? Abnormal connection. So here we have the bladder. This is just a representation of the bladder. This is a representation of the abdominal wall. You see here, it has degenerated. That's why it is in black. You see, this is the normal scenario. So what about if it does not degenerate? So we have the bladder here, and you have the abdominal wall, right? So who is this? Kindly mute Samuel Chamber. Okay, so you see you have a fistula. So it means urine will leak through the like the navel, because that's the only opening you have. So you have like the a sinus. A sinus, as I'd said, it's a tract with a blind end. See, it's like starting well like here, but then it has a blind end. So this is the it's called the urachal sinus. And then you have a cyst. It's just a cyst because we have like this something at the center here. Okay, then we have a bladder diverticulum. So it's called a bladder diverticulum because the urethra has become a ligament on the upper part, which is good, and the lower part it has not become. So the lower part looks like an extension of the urinary bladder. Okay, so this part looks like it's an extension of the urinary bladder. That's what's called a bladder diverticulum. Okay, now to the last, okay, the second last. So we have the chorionic plate. So the chorionic plate is consists of these three things. We have the somatic layer of the extraembryonic mesoderm, somewhere here. This one here, I'm not sure about this color. Is it brown? And then you have the syncytiotrophoblast and the cytotrophoblast. So these are the that this is the what is the chorionic plate. So we have the chorionic frondosum and the chorionic leaf. So the chorionic frondosum is the bushy chorion. So you see, if you like look here, we have like less chorion, and then here we have like more. Here it looks more bushy, right? So it's the part of the chorion that has a lot of villus projection. You see, like here it has like there's a lot of villus projections, and then chorionic leaf there's like less villus projections around here. So this is chorionic frondosum, and then this is the chorionic leaf. So the functions of the chorion. So the chorionic frondosum usually forms the fetal component of the placenta, right? So like this is the chorionic frondosum here. Okay, so it usually forms we'll discuss the placenta in a few. So this is the chorionic frondosum, and then now the maternal, like the decidual basalis usually now forms the maternal bit of the placenta. So this is the fetal component of the placenta, and then yeah, this is the fetal component of the placenta. It's called chorionic frondosum or bushy chorion. So the chorion also protects the embryo, and it's also a site of hemopoiesis during the yolk sac phase, not like later in life. Only during the yolk sac phase, it's when it produces blood. Yeah. So clinical utility of the chorion. So diagnosis of early pregnancy, like it's a chorion. I believe you've ever heard of something known as beta HCG, beta human chorionic gonadotrophin. So this chorion produces this hormone. This hormone is what is used to detect pregnancy. Like you see in these pregnancy kits, we usually detect for beta HCG, right? So it also can be used in the visualization of the gestational sac. So we have the chorionic cavity here. You see, like this here we have like one child, and then here we have like two gestational sacs. So this is a twin. So it can be used in the visualization of the gestational sac. So chorionic villus sampling, the one I was discussing earlier, it can be used in genetic studies, right? So chorionic villus sampling, an advantage of it over amniocentesis, it is that it can be done earlier uh, as opposed to amniotic fluid. So I'd say the amniocentesis, we have to wait for amniotic fluid to form. But here, chorionic villus sampling, you can do it earlier. But the disadvantage is that it's high risk and can lead to bleeding. So I'm really emphasizing this on amniocentesis versus chorionic villus sampling. So after this lecture, go read about it because I'm sure you might be tested about it. Like the advantages of amniotic villus sampling of what do we call this? Chorionic villus sampling. As in advantages of amniocentesis of a chorionic villus sampling and advantages of chorionic villus sampling of amniocentesis. So kindly go read on that. So yeah, this is basically the chorionic villus sampling. You're just sampling the chorionic, like the chorion, right? So this is how you do it. You see, like even you look at how you approach it. You can approach it transcervically or transabdominally. See, it's high risk compared to this. Yeah, so go read the disadvantages and advantages of each. So the placenta, it's a fetal maternal organ. So the fetal bit of the placenta is the chorionic frondosum. So this is the bushy chorion here, as I had shown you earlier. So this is the bushy chorion. So it forms the fetal bit of the placenta, and then the maternal bit is usually formed by the decidua basalis. So the decidua is basically endometrium during pregnancy. Like the endometrium during pregnancy is usually filled like usually enlarged with glycoproteins and all. So it's basically decidua. Just when you hear the word decidua, it's just the endometrium during pregnancy. And there's usually three types of decidua that you must know: the decidua basalis, parietalis, and the decidua capsularis. So this is the decidua basalis. This one here, the decidua basalis, it forms the fetal bit of the maternal bit of the placenta. Then the chorionic frondosum forms the fetal bit of the placenta. Then we have the decidua parietalis, this one around here. See, this is the decidua parietalis. Then the decidua capsularis, it covers the pregnancy itself. So yeah, so this is the decidua capsularis. It usually like covers the pregnancy itself. Okay. Yeah. So the placenta, it's the functions is exchange of oxygen, carbon dioxide, nutrients, antibodies, from fetus to mother and mother to fetus. So you're supposed to know like the direction of how is oxygen going from fetus to mother or mother to fetus. So you can just work out that it's not hard. And also it has endocrine functions. Like this beta SG enables persistence of the corpus luteum, then so that the corpus luteum can produce the progesterone. Progesterone is, as you know, is usually in maintaining of the pregnancy. Just you have other hormones like estrogens and HPL, the human placental lactogen, which is important in breast development. So congenital anomalies. So again, I'll start with the pictures and then go to read this slide for you. So yeah, you have this slide here. But then these things Beda might bring for you in the spot. So it's good to know them. So this one, the first one here, it's the placenta previa. So here we have a low-lying placenta, right? So in a low-lying placenta, it means the only way that this baby can come out is if the placenta comes out first. And if the placenta comes out first, that is catastrophic. See, placenta previa, it's a low-lying placenta. It obscures the birth canal. So the placenta must come out of the baby before the baby. And when the placenta comes out before the baby, you will definitely cut off the oxygen supply. Yeah, so this is the placenta previa. Sorry. Then we have this called battledore. Yeah. So this battledore, the umbilical cord is attached to the edges of the placenta instead of the center. See, like here, this is a normal, this is how it's supposed to be. The umbilical cord should attach to the center of the placenta. But you see here it does not attach the center, but it attaches to the edges. So yeah, so this is battledore. Then here this is called a bilobed placenta. Bilobes because there are two lobes, right? Yeah. So it's bilobed. So two plus like not supposed to use this word two placentas, but like two parts. I'll correct this, like two parts. So and then you have the circumvallate placenta. So this is the circumvallate placenta. Like the edges, like it looks like they've everted, right? So yeah, so this is the circumvallate placenta. So the placenta with everted edges. And then here we have this is called placenta velamentosa. So here in the placenta velamentosa, there is branching of the umbilical cord before reaching the placenta. Okay, see, sorry. This umbilical cord branches before it reaches at the center. You see, like it's abnormal. It's called placenta velamentosa. Yeah. Then we have an extra lobe of placenta